Welcome to Allergy Morning Commute, Diagnosing Hereditary Angioedema and Establishing the Treatment Plan. Morning Commute is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from BioChrist. In this podcast, the first of a two-part series, Dr. Mark Rydell and Dr. Alina Banerjee discuss hereditary angioedema. How easy is it to miss this diagnosis? What do clinicians need to have on their radar to distinguish HAE from allergic reactions? Doctors Rydell and Banerjee provide the roadmap needed to ensure these patients get on the right track to managing their disease. Information about the faculty and disclosures can be found at morningcommutepodcast.com/HAE1. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Rydell is a professor of medicine and the clinical director of the Angioedema Center at the University of California, San Diego. Dr. Banerjee is an associate professor of medicine in the Division of Rheumatology, Allergy, and Immunology, and clinical director of Allergy and Clinical Immunology at Harvard Medical School in Boston. I am your host, Candace Hoffman. Dr. Rydell will begin our discussion.
Hi, everyone. I'm Dr. Mark Rydell. I'm a professor of medicine and an allergist immunologist at the University of California in San Diego. And I'm joined today on this podcast by Dr. Alina Banerjee. Dr. Banerjee is at Massachusetts General Hospital and Harvard Medical School. Alina, thanks for joining me today.
Thank you. I'm excited about our conversation today.
Excellent. So we're going to talk a little bit in this podcast about hereditary angioedema. And I first think let's cover how we recognize this condition, how it presents clinically. It can be a little bit of a challenge, Alina.
Thanks, Mark. I think that's a great place to get our conversation started. The biggest factor that I think leads to a lot of confusion is somebody presents with symptoms of swelling. And swelling can certainly be misinterpreted for a lot of different things. And that includes an allergic reaction, it includes insect bites, and often those are things that are more common. And if anything, identifying those symptoms of swelling that then lead someone to think about hereditary angioedema may actually be the more important aspect of this. And so the things that I often think about or tell my colleagues or our fellows when we're talking about these cases is to think about someone that comes with recurrent episodes of swelling. They should not have any itching, and they shouldn't have any hives or urticaria, because that is not seen in patients with hereditary angioedema. Is there some other aspect in the clinical presentation that you're thinking about when you're discussing these cases with your own colleagues and fellows?
Well, I think as you said, hereditary angioedema or HAE, it is a swelling condition, and it affects usually the skin. So usually there's visible swelling that one in the healthcare field can recognize, episodes of facial swelling, hand swelling, even urogenital swelling, which can be really embarrassing and uncomfortable for people. What can be tricky about hereditary angioedema also is that it can affect the GI tract. So people will get swelling of their intestines, which can manifest as abdominal pain that goes on for a few days and can be actually very severe to the point where they end up at the emergency department or the hospital. And of course, abdominal pain has a huge differential diagnosis. So people will be mistaken for having appendicitis or pancreatitis or a gallbladder issue. Women are often told they must have a gynecologic problem because it's abdominal or pelvic sort of pain. So the GI symptoms can be very prominent in HAE. These episodes, as you said, recurrent episodes of abdominal pain and or skin swelling, mistaken for other things. And the other issue is the airway. I mean, as you know, Alina, this is a life-threatening condition if it hits the airway. And so that's another issue that can be not only frightening, but deadly. These people can die from asphyxiation. And so taking that into account is important. The other challenge we run into is these people will see multiple specialists or be seen in multiple healthcare settings.
I agree. And so, there's a few key things to think about. And like you're saying, a lot of this is having episodes that are unexplained and they keep getting a different diagnosis, or they keep going to the emergency room, or they've had surgery for appendicitis, but when they look at the pathology of the appendix, it's normal. Another common one that has come up in my experience is the child that complains a lot of stomach pain or goes to the nurse's office frequently, and they're misdiagnosed as a problem child or someone who just doesn't want to go to school, instead of thinking about hereditary angioedema. And so I think that really sitting down and getting the history, also the family history. So we know about 3/4 of patients with hereditary angioedema with C1 inhibitor deficiency will have a family history. So certainly it's helpful if it's there. It doesn't rule it out if it's not there, because we know that about 20-25% of patients will not have a family history, but certainly understanding if there was a sudden death, if there were family members with frequent episodes of unexplained swelling. I think all of those are important pearls to think about when we are seeing these individuals for evaluation in our office.
Yeah, that's so important. And just to emphasize that for a second, I think in my experience, having been in medicine for a while now, longer than I'd like to admit, but we tend to gloss over the family history a lot. I think this is a condition where it's actually really important to take that family history. Are the parents that have similar symptoms? Are there other first degree relatives that have these sorts of swelling episodes? So that's really important to ask and listen to the family history, because as you said, not all the time, but about 75% of the time, you're going to get other family members that have similar symptoms. And that's a huge clue to making the diagnosis of hereditary angioedema. Just a couple other facts to expand on that you brought up. This is a genetic condition. So it's autosomal dominant. And that's, of course, why we see multiple affected family members much of the time. And it's rare. So as you mentioned early in our discussion, it's not the most common thing that causes swelling, skin swelling or abdominal pain or airway issues, but it is a very important one not to miss. And so we think the prevalence is about 1 in 50,000. So there's several thousand patients in the United States. And that number, that prevalence seems to hold true globally for the most part. And then one other thing, just to reiterate or emphasize what you said, this really is a pediatric condition, right? It shows up symptomatically, usually in the vast majority of patients before the age of 20, usually during childhood, although some people won't have prominent swelling symptoms until their teenage years, till their adolescent years. But to your point, this is something to think about in pediatrics. And because the earlier we can make the diagnosis, the quicker we can get people to effective treatment. And the treatment of HAE is quite different compared to allergic angioedema or other types of swelling. So being mindful, keeping this on the differential diagnosis, and then doing the testing is really, really important to get people the right therapy.
I agree, Mark. And to stress that really important point is, if you're seeing someone who's in their 60s or 70s for their first episode of swelling, we probably need to think about other conditions other than hereditary angioedema with C1 inhibitor deficiency. Certainly there are some bradykinin-mediated conditions that could occur in the 60s and 70s for the first time, but I think it's an important clue if they've gone 50, 60 years of their life without any swelling, that maybe hereditary angioedema, specifically with C1 inhibitor deficiency, is less likely going to be the diagnosis there.
Right. So let's take this into the clinic for a second. So you and I do a lot of this, and I want to pick your brain for a second. So you have the patient that comes in, they tell you they've had recurrent facial swelling, maybe some abdominal pain. And as you mentioned, the first thing that pops into a lot of people's heads, and we're allergists, so we're a little biased, but is allergy, right? Oh, there must be an allergic reaction to something. That's what's causing your face to swell or your tongue to swell. So walk me through what kind of questions do you ask to try to get at whether this is truly an allergy problem, because many times it may be, versus this sounds like something different and we really should test for hereditary angioedema. What kind of questions do you ask?
Yeah. Mark, thanks for bringing it up that way. As we're seeing these patients, one of the things, or several things that we often think about, which I briefly mentioned, is it just swelling, or is there associated symptoms of itching or pruritus? Are there associated hives or urticaria? I think is really an important place to start. The other important factor is how long do these episodes of swelling last? Does it last for 2, 3, 4 hours and then it resolves? Or does it really last for 2, 3, 4 days from start to finish? Because when we think about hereditary angioedema or bradykinin-mediated angioedema, those symptoms tend to last longer and several days. And part of that is the pathophysiology of what we're talking about when it's not histamine, but instead the bradykinin that causes vascular permeability and explains the symptoms of swelling. And then it takes several days for the body to resorb that fluid that led to the symptoms of angioedema from the vascular leak. Other factors that we will often ask about is, are there any triggers? Did they start an ACE inhibitor recently? Did they use aspirin or ibuprofen when these symptoms are occurring? And usually that doesn't lead to anything, and because that tends to be more obvious. Otherwise, foods, did they eat shellfish on those 3 occasions when the swelling occurred? And again, those tend to be a little bit more obvious, especially for us in the allergy office. And so those aren't really as obvious, and they come to see us. Another thing that we often will ask patients are pictures. They may describe swelling, but sometimes when you see the picture, it could be large urticaria. And I think the pictures really make a useful addition in the evaluation. And if they don't have pictures with them and they say they've had 50 episodes, then we really do need to go back to square one and say, okay, well, next time you have an episode, take a picture, you can send it to me, because I think that's a better way to proceed. How about in your office, Mark? Are there other things that you're thinking about when you're seeing these patients that I didn't mention?
Yeah, very, very similar approach. I mean, I'll just say photos are hugely important and helpful. And, again, showing my age, coming from an era where you had to go to take the photos to get them developed. Now everybody has a camera. So it's really helpful to have photos of that hand swelling, that facial swelling, any sorts of skin symptoms, because to your point, there are some nuances that the photographs can really help us answer. It's, of course, more difficult for the abdominal symptoms and certainly airway symptoms. We unfortunately don't usually get images of those sorts of attacks, although if the patients are seen in the hospital or the ED for abdominal pain or airway issues, sometimes CT scans can be helpful. We don't know how sensitive those are at picking up swelling of the bowel, but sometimes it's quite clear that there's small tracts of, usually the small intestine is the area of trouble. So that can be really helpful if it's present. And for the airway, of course, people, we always want to take a history. Have you been in the ICU? Have you had to have your airway managed? Have you had a laryngoscopy that showed evidence of angioedema? All of these sorts of objective findings are really very helpful, along with, as you said, listening very closely to the history. And so, I totally agree with you. HAE attacks, because of the mechanism or the pathophysiology, and we'll talk about that a little more in a second, but because this is bradykinin mediated and has really nothing to do with the allergy system, it does follow a different trajectory. These swellings tend to develop more slowly, become severe over a period of several hours in most cases, whereas allergic reactions are usually much more rapid onset, become severe more quickly. And as you already mentioned, these HAE swelling episodes, if it's the skin or the abdominal tract or the airway, they're protracted. If they're not treated with an effective bradykinin targeted medicine, and again, we'll get to that later, they will last for usually days, for 2, 3, 4, 5 days. So these are not sort of, little bumps in the road. These tend to be very debilitating. painful and dangerous symptoms for a few days at a time. The other thing I really like to ask patients about, and it's not a perfect litmus test, but what treatment have you received? Most of these people, as you said, they've had recurrent episodes. So this is not a one-time deal. It's happened over and over, over weeks, months, or even years. And so they've usually received some treatment, either from their primary care physician, from an urgent care, from an emergency department. Patients are pretty good at telling you what helps and what doesn't. So most of them have had treatment for allergic reactions. They've had antihistamines, corticosteroids, even epinephrine. And to be clear, those don't do anything to improve HAE attacks. Their HAE swelling is entirely resistant to those allergy medications. So that's an important piece of information to gather. Have you received those sorts of treatments? Did you get better? If people turn around in a few hours with those therapies, as is usually the case for allergic reactions, then it's pretty unlikely that they suffer from HAE. So response to previous treatments is also, I think, a clue that we should be asking about in the history. So Alina, as we've talked to the patient, we've gathered some historical information, we've gathered their symptoms, and let's just say for argument's sake, they have a pretty good story for HAE. They have these protracted episodes. They receive lots of allergy medications that hasn't either prevented or resolved these acute episodes. What do you do next? What's the next step in sort of moving towards evaluating for HAE?
Yeah, that's a great question in terms of next steps. And if we can go back for 1 second, I just wanted to highlight what you just mentioned about the lack of response to certain therapies. We know that in the spectrum of chronic spontaneous urticaria and angioedema, those individuals, 20 to 40% will present only with swelling. And so I think that we really have to think about using high doses of antihistamines, thinking about montelukast, maybe even a biologic, to show that they're not histaminergic. And so I just wanted to highlight that point because I think it's really important for us, even in individuals that are presenting with recurrent symptoms of swelling, to make sure it's not histaminergic.
Yeah, totally agree. But let's talk about testing, because before we go through all these machinations to prove or disprove its allergy, we actually have some simple tests we can send to look for a different problem. So agree, but go ahead with the testing.
Yes, back to your question. There are some very black and white, simple blood tests to help us diagnose hereditary angioedema with C1 inhibitor deficiency, and includes a C4 level, a C1 inhibitor level, and a C1 inhibitor function. And what we're talking about here is to identify the first main two types of hereditary angioedema. And type 1 is about 80% of individuals where there's a low C1 inhibitor level and a low C1 inhibitor function, because you're not actually producing a protein that is working. In type 2 hereditary angioedema, which is about 20% of individuals, what you have is the C1 inhibitor protein being produced. And so that level, the protein level, is normal, but the protein doesn't work properly. And so you'll actually have a low C1 inhibitor function. And so really the gold standard is to make sure you always look for a C1 inhibitor function. Certainly there's a screening test, the C4 level, if you're thinking about just a quick screening test. But in rare cases, you will see a normal C4 level. But the majority of cases can be identified with a low C4 level. And genetic testing is not really part of standard of care in most cases. It's really starting with these 3 lab tests for hereditary angioedema with C1 inhibitor deficiency.
Right. So as you've said, most HAE is caused by this protein deficiency, C1 esterase inhibitor deficiency, or C1 inhibitor for short. And you just outlined perfectly the test. And so that's really what I was getting at in my point. If you see a patient that just has swelling, no hives, no other sort of allergy symptoms that would suggest an allergic reaction to some exposure, it's worth sending this panel of labs, the C4 level, the C1 inhibitor level, and the C1 inhibitor function. And with those 3 tests, as you just outlined, you can pretty effectively either identify a patient with HAE due to C1 inhibitor deficiency, or exclude the diagnosis and say, no, everything looks normal there. We move on to other things. And C1 inhibitor deficiency, we know, is caused by mutations in this gene called SERPING1. You can sequence that gene. We all know sequencing has become more and more available. There are ways to do that through commercial labs now, but you already said it. We don't need to do that most of the time because these biochemical tests are pretty darn accurate if ordered. But you got to think of a diagnosis, right? You got to order those labs to be able to say anything about whether this is HAE or not. So that may be the biggest barrier, frankly, is thinking of the diagnosis, ordering the tests. These tests are fairly widely available across the U.S. So Alina, most patients are going to be picked up by this sort of testing. We don't want to get too far into the forest here, but do you want to say a word about the very, very rare types of HAE where this testing doesn't pick up the diagnosis?
Yeah. So there's the condition of hereditary angioedema with normal labs. And in these cases, the symptoms are very similar to those patients presenting with hereditary angioedema with C1 inhibitor deficiency, except maybe a slight predilection for the face or the tongue compared to the periphery and so on, as we talked about. But there are specific genetic mutations that have been identified. Very few labs are actually able to look at these genetic mutations, but there certainly are some clear genetic mutations that have been identified, but certainly still cases where we're not able to identify the genetic mutation, but the clinical symptoms are very similar.
Right. So thanks for covering that. These are very, very rare patients, but they do exist, and it's important to at least be aware of that condition, HAE with normal C1 inhibitor, which is frankly a difficult diagnosis to make a lot of the time. Which I guess brings me to a final point that we should touch on, Alina, is, this is a rare condition. The diagnosis is usually fairly straightforward by the blood test, but when should a patient be referred to a specialist in angioedema, particularly as we move in our next podcast? We'll talk about management, and there's some important management points. But, is this something that every patient should see a specialist, or some patients should see a specialist? What's your take on that?
I don't think there's a right answer there. And I think that my perspective is if it's a physician who has a lot of comfort with hereditary angioedema, I think it's certainly reasonable. But if it's somebody who really has one patient, maybe to work with a specialist in conjunction to make sure that the newest and best treatments are being used, that the guidelines are being followed, and certainly the physician can learn that. The other thing that I think is more important is when the diagnosis is not clear or the therapies aren't working, and I'm sure we'll talk a little bit more about that in the next session. But I think those are times where it makes a lot more sense to refer to an HAE specialist.
Yeah, I totally agree. And I think we're gonna move towards management in the next podcast. But just to reiterate, we've talked about recognizing the symptoms, making the diagnosis, typically with the C1 inhibitor, laboratory testing, and just to put a cap on it, the reason this is so important is because the management of HAE is very specific. There are very specific targeted medicines that have been developed to treat HAE based on the pathophysiology, which again is the kallikrein bradykinin system, not the allergy system. And so making this diagnosis completely changes the management of a given patient. And in fact, it can be life-saving because again, this is a debilitating and life-threatening condition. And it's so important that we get these people the right therapy, which, as you just said, Alina, often does involve getting an HAE specialist to collaborate with. So, well, Alina, thanks very much. This was a lot of fun. I've enjoyed it, and I hope it's been useful to all you out there in the audience. Thanks for listening.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/HAE1. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.